All right. Welcome, everybody. Thank you so much for being here. Good evening and welcome to NAMI Eastside's monthly forum for mental health education, sponsored by Evergreen Health and tonight by Connections Health Solutions. My name is Edie Myers-Power, and I am the Youth and Education Programs Coordinator for NAMI Eastside. If you haven't already, drop that zip code and city in the chat box for me. I see most of you have done that already. Thank you so much. Knowing that information helps us fund programs like these in the future, so thank you. And I'm pleased to introduce you to tonight's speaker, Heather Genovese from Connections Health Solutions. Tonight, Heather joins us and will be talking to us about Connections' plans to open a 24/7 behavioral health crisis response center to meet the unmet needs of North King County. This center will be located in Kirkland, and Heather will walk us through their care model, the services that will be offered at the center, and examples of how our community can support and get involved. And with that, Heather, you can go ahead and take it away whenever you're ready.
Wonderful. Thank you all for joining this evening. It's nice to be able to get to see some of you and meet with some of you. This evening, I'm going to do an overview of the behavioral health crisis care landscape as we have experienced it within Connections over the course of the last probably 20 years. Provide you a Connections history and our expertise in crisis care. Provide you what our crisis service overview is, and then the impact and results, and then the next steps that we would like to be able to take with the community. I'd like to ask that if you have questions, you can drop those in the chat, but I will address those all at the end. I want to make sure that I'm able to get through the presentation. I have quite a bit of information that I'd like to share with you this evening. So we'll just start in. Connections' mission is changing the face of behavioral health through a physician-led, data-driven care that creates positive, lasting change and gets people back to their lives faster. Connections isn't just our name, it's what we do, and it's why we do what we do. We want to connect with individuals, both in the external stakeholder department and also within the community and the people that we're going to serve and provide services to. A little bit about our history. Dr. Chris Carson is one of our founders, and he was one of the pioneers in the high acuity crisis observation model in Fort Worth, Texas. He then began working with Dr. Robert Williamson, our second co-founder, and they began to refine the model to improve the access of care to all people. And that was in their observation unit in Dallas, Texas. In 2007, Drs. Carson and Williamson came to Arizona. Dr. Carson assumed the responsibility for the crisis system in Arizona, and he brought Dr. Williamson in to assist in turning around what was then our Phoenix Urgent Psychiatric Center. Dr. Carson and Dr. Williamson set the Arizona standard for all crisis facilities and pioneered the model of no wrong door. And then with that being said, really focused on law enforcement drop-off times. So with the no wrong door, I'll get into that more, but law enforcement is one of our biggest partners within the system. In 2009, Connections Health Solution was founded and assumed the ownership of the Phoenix Urgent Psychiatric Center. We then expanded in 2014 to Tucson, and we assumed the management of our crisis response center in Tucson. 2021, the National Council released the Roadmap to Ideal Crisis System, and it was co-authored by Dr. Margie Balfour, building on the Crisis Now model. Many of you have potentially heard or seen Dr. Balfour speak. She's a thought innovator and really leads the charge in how we can provide ideal crisis services. In 2022, we expanded to Bozeman, Montana, and our services in Bozeman, Montana are for mobile crisis services. In 2023, we have begun our national growth, bringing our immediate access and community-based crisis model to several counties across the country, including in Kirkland, Washington, and then in Woodbridge, Virginia. So What's really important to understand is we have a 100% acceptance rate at our Connection Center. We do not turn anyone away, whether it's concerns around ability to pay, needs that they have, we will accept everyone. There is no person that gets turned away. Again, we were founded in 2009, and we treat roughly 30,000 individuals annually at our 2 Connection Centers in Arizona. So the Arizona crisis system is one that has taken some time to develop. And so right now, if there's a person in crisis in Arizona, they can call 911 or now 988, which is a wonderful crisis line that is nationwide now. 80% of those calls to a 988 are resolved. And of those 20%, mobile crisis may need to be pulled in. Mobile crisis therapists and providers are able to resolve issues and services 70% of the time in the field. Of that, the 30% that's left, we go ahead and we ask them to bring or refer individuals to the acute crisis facility. Once individuals are at our acute crisis facility, we can discharge 60 to 70% of those individuals back out to the community so that they can be back in their community, back with their loved ones, and around things and people that they know. The 40 to 30% that's left of those individuals that are not able to be discharged back into their community, we do community and residential care inpatient stabilization. And once we discharge those individuals, and I'll get more into what that looks like in a few slides, 85% of the individuals that we're able to discharge back to the community-based care, whether it's an outpatient care or crisis respite, 85% are able to stay stable and remain stable within 45 days. So we're not seeing a lot of recidivism coming back through. So the result in this process and the Arizona crisis system is that we have decreased use of jails. That's not where individuals having a psychiatric emergency should be taken. They don't provide psychiatric care. And we're seeing decreased numbers and time and use spent in the hospital and the emergency departments. They're also not a place where individuals should be receiving emergency psychiatric care. So within Connections, we prioritize access for everyone. Any individual in need of behavioral health care, inclusive of high acuity, violence, agitation, are going to receive treatment regardless of insurance status or their history. We accept 100% of individuals that come to our door, no exceptions and no judgment. We believe in the least restrictive care available for an individual. 65 to 70% of the individuals are stabilized and discharged within 24 hours. Should they need additional stabilization, the average length of stay for our inpatient unit is 3 to 4 days. We're creating connections within the community. My colleague, Sarah, who wasn't able to join us this evening, she and I have been traveling to the Kirkland area to meet with stakeholders, to meet with the EDs, the transportation folks, law enforcement, first responders, fire department, to connect with them to identify what's working well, where the gaps are that we can fill, and then to continue to identify gaps that will still exist so that we can reduce those as much and as often as possible. 90% of individuals that we discharge from our care have an outpatient follow-up appointment within 7 days. That's critical to ensure that that recidivism back into crisis does not occur. So our model is 4-pronged. We have an urgent care, and I'll get more into detail, but the gist of the urgent care is very similar to what we would do now if we had a medical emergency or a medical need. You've cut your finger at home, you need stitches. You wouldn't go to the ED necessarily for that. You would go to an urgent care where they could stitch you up, you get treatment pretty quickly, and you can get in and out and back home to your family. We have walk-in access to psychiatric providers within 90 minutes. So 90 minutes from the point that somebody walks in our front door, they're going to see a psychiatric provider. Our second level would be our 23-hour observation. It's rapid assessment, treatment, and stabilization with proactive discharge planning that all occurs within 23 hours and 59 minutes via an interdisciplinary engagement. In the event that that 23 hours is not going to be suitable to stabilize someone to be safely released back to the community, we have our crisis stabilization units. And that's for someone that just needs a little extra time to continue to stabilize and potentially needing additional services set up for that continuity of care once they are discharged. And then our transitions program is our ongoing follow-up. It's post-crisis, and it's a warm handoff to community care. We're really looking to bridge and act as a liaison between the individual receiving services and any external provider that we can connect them with. Perhaps they have an outpatient clinic that maybe things went sideways, or they haven't shown up, or they can't get an appointment. We're going to act as a liaison to ensure that the connection with that outpatient provider is reestablished, and we set up appointments to make sure that there's a follow-up. In our transitions, though, we'll continue to provide therapy, we'll continue to provide psychiatric care, and it is a stopgap just for a moment until we can connect folks back to their health home. So urgent care, as I said, once an individual walks in our front door, they're going to be greeted. They're going to be, thank you for coming in. How can we help you? And that individual is going to get treatment in about 90 minutes. We're going to provide an assessment and a treatment plan. It's delivered by a behavioral health medical provider, and it's going to address the immediate needs that the individual is presenting with. There's going to be a psychiatric assessment, a psychosocial assessment, and a medical assessment for the individual. We're going to provide comprehensive discharge and follow-up planning for the individual. And walk-in patients meeting a medical necessity for a 23-hour observation are admitted. There are times when families bring a loved one or an individual comes in and they realize that they're not safe in their community. If that is the case, we can admit directly to our observation unit to ensure the safety of the person that's presenting themselves to us. The teams that we have in our urgent care are behavioral health medical provider. It's a doctor, a medical doctor, a nurse practitioner, physician's assistant. We have registered nurses, licensed caseworkers, and behavioral health technicians that are all going to meet with the individual throughout the course of their urgent care services. And our outcomes for that level of care, less than 90 minutes, door to behavioral health medical provider. The last time I went to urgent care to have a test done for a medical concern, it took far longer than 90 minutes to see a provider. So we pride ourselves on making sure that individuals can get care immediately when they're trying to access it. And within our urgent care, we have a 95% patient satisfaction. That's really important to us, that we ask individuals for their feedback for us so that we can continue to improve and grow in the services that we can provide. Our 23-hour observation is a unit that prioritizes treatment, not triage. We're not triaging folks. We are admitting them, and they are going to be admitted into an observation chair. There's a photo here of what those look like. It's a comfortable recliner under continuous observation from our nursing bay. In addition to that, we have recovery support specialists and behavioral health technicians that are on the floor meeting with individuals, checking to make sure that they have their needs met. There's an orientation to the unit so that they understand where the restrooms are, where showers are. We all have colored scrubs depending on the discipline that we are. So they're informed and educated and shown where the legend is. We have printout legends on the windows to show individuals, if you want to speak to a doctor, this is the color scrub that you're going to look for. And you can ask for someone at any time. The interdisciplinary team is going to provide immediate intervention, medication, detox or MAT services, medication assisted treatment, crisis counseling, peer support, safety planning, mindfulness. We're really looking to provide all of the necessary counseling and psychiatric services that we can within those 23 hours. Our team is going to collaborate and coordinate with community and family partners to create a successful discharge plan. From the moment an individual hits our door or walks in and says they're seeking services, we're going to work on that discharge plan from the get-go. We don't want to hold people longer than they absolutely need to be with us. The goal is to get them stabilized. The goal is to get them safe, to get to feel better, and then to return back to their community. Again, our behavioral health medical providers, MDs, NPs, and PAs. We have registered nurses and licensed practical nurses, licensed case managers, behavioral health techs, and peer support specialists. We feel that the peer support specialists are a really critical piece to the care that we provide. And these are individuals who have lived experience. Several of the peers that we have in our Arizona facilities actually received services from us at a certain point in their life. They were assisted, they became stabilized, they are engaged in their own recovery, they've gone through peer support training, they become certified, and then they come back and ask if they can assist others in our care and be employed by us because of the care that they received when they so critically needed it. One of the other ways to get into the 23-hour observation is what we call our back door. And that's where our law enforcement and first responders have a dedicated door. It's typically located in the back, which is hence the back door. They have a dedicated door. They'll ring a bell. Our staff respond and take custody of an individual that they're bringing to us in 5 minutes. That's very quickly. We want to make sure that that officer can go back out onto his patrol and do what they need to do. There are times when we have individuals who are being brought in by law enforcement that are not voluntarily coming, and they may in fact have handcuffs on. Our staff all have handcuff keys. We work with law enforcement to help them understand that our goal is to remove those handcuffs ourselves and not leave that to the officers. The reason for that is we want to begin building that rapport and begin building that relationship with an individual to let them know they're in a safe place, that we are not the police. We're a treatment team. Typically it's our peers who are removing those handcuffs. And regardless of who's actually greeting them, typically what we're saying to them is, thank you for coming in today. Even in the midst of a crisis, folks need to have humanity and dignity being provided to them. And that's part of how we connect with individuals. Our outcomes from our observation is we have about 60 to 70% of the individuals who are brought in involuntarily convert to voluntary status during that 23 hours. That's really critical because it gives them the power, it gives them the autonomy to make decisions about their psychiatric care. So 60 to 70% move from involuntary to voluntary, which I think is pretty wonderful, given the fact that we've got folks who are coming in that are pretty agitated and sometimes quite upset that they've been brought in. We have so our dedicated first responder, again, entrance offers secure, simple drop-off. Our law enforcement officers are a critical partner, and 50 to 55% of our drop-offs annually come from law enforcement officers. Our partnership has been so successful within Connections that we play an integral role in the Tucson Police Department's learning site designation. Communities nationwide visit our Crisis Recovery Center in Tucson to learn the best practices for police mental health collaboration. Sergeant Winsky just was with Sarah and I when we visited in September, earlier this month, and he met with the chiefs of police and the sheriff's partners and presented to them and answered their questions. Law enforcement speaks a very specific language, and having an officer provide information to law enforcement in the Kirkland area is really critically important for us so that they understand we're not coming in and just saying, this is what we're going to do. We have an officer who's worked with us, who has his teams coming to our facilities, and can speak to the fact that, in fact, what we say we do is actually what happens. And that goes a long way to getting the buy-in from law enforcement to bring them to our facility rather than taking them to jail and booking them, or taking them to the emergency departments and having them, basically being boarded in the emergency room without receiving psychiatric care. We have a less than 10-minute law enforcement drop-off time that can vary sometimes depending on whether or not the person is coming in what we call hot. If they're super agitated, it might take a few moments longer for us to get that individual calm in a place where we can remove the handcuffs and take custody of them. Typically, it's done in 5 minutes or less. We have a less than 3% of our individuals brought to our back door are transferred to the hospital for medical clearance. Truly, the only individuals that we would send to the emergency room are folks that we have grave concern that they're in acute medical distress. We're not going to send folks to the emergency room because their behaviors are too big, or because we can't clear them medically. If folks have good vitals and our providers are there and are checking those vitals, we're going to go ahead and provide care to them. Again, in that moment, there are folks who go into acute medical distress, and we're going to go ahead and make sure that their medical needs are met first. And then we're going to ask the emergency room to send them back to us. We want to be able to provide the psychiatric crisis services for that individual. We do not turn anyone away from our law enforcement entrance ever. We have a 0% turnaway rate. And Sergeant Winsky was very clear with the chiefs of police when we came up and the sheriff's office that is a fact. No one gets turned away. And peer support specialists, again, are a really critical piece to this law enforcement. They too have oftentimes been brought in for a psychiatric crisis by law enforcement, and they help individuals understand and calm them that what they're going to receive with us is care, compassion, and dignity. And we're not going to make them do anything as long as they're being safe, right? So, in the event that an individual is not able to be discharged safely from 23-hour observation, our docs are going to be working with that individual. They're going to be getting collateral information. They're going to be collaborating with the family and their natural supports. If they're not able to be safely discharged, we're going to admit them to our inpatient facility. This is the best part about our services is we have continuity of care within our own facility. The collaboration between providers from one level to the next is immediate and automatic. They can actually meet face to face if there are questions. There's no need to play phone tag or email tag. Patients are admitted to our inpatient crisis stabilization if they're not stabilized within the 24 hours, and they require between 3 to 4 days additional stabilization. The same interdisciplinary team that they receive services from in our 23-hour observation, it's going to be the same multidisciplinary team in our inpatient facilities. We're going to continue to monitor, assess, and evaluate individuals. And we also have enhanced group programming options that are available to individuals. We do have licensed case managers who are able to provide individual and or family counseling if that need comes up. And folks that are being provided services out of our inpatient have a 90% satisfaction rate. So post-acute transition program. Our transitions program is really revolutionary in that we want to make sure that once we've identified an individual is safe and secure to be discharged back to their community, that there's no gap in treatment. Oftentimes there can be a long wait time to get back into an outpatient services. Their doctor could be booked out for months. We want to make sure that that individual is getting the right care at the right time from the right people. Once they're admitted into our transitions program, they're going to have a comprehensive treatment plan that's developed with them. The program includes access to psychiatric provider for evaluation and medication management. We're not going to allow someone to not continue with the medication regime that we provided for them to get them stabilized and safe. There's going to be short-term therapeutic interventions by our licensed therapists, and peer support services with a dedicated peer recovery specialist will also be provided to each individual. We continue to do care coordination with primary care, specialty providers, and the community resources and agencies. It's really critical to us that that person receiving services is reintegrated back into their community, that they're getting the services that they've identified that they need, and that our providers have identified. The team in that program consists of our behavioral health medical providers, registered nurses, licensed case managers, behavioral health techs, and peer support specialists. About 90% of our individuals have a 7-day follow-up, outpatient follow-up, and we have a twofold increase in primary care engagement. We know that oftentimes primary care does not have a lot of openings, but we make sure that there's that handoff to primary care and we connect folks with them. We also know at times folks are auto-enrolled in a Medicaid program and they may or may not know who their primary care provider is. We will connect individuals to their primary care as well. Let's see. So our outcomes. Connections is setting the national standard for the way that we provide crisis care. 65 to 70%, we have a 65 to 70% community disposition rate, 60 to 70% conversion from involuntary to voluntary. Again, we have more than 90% of our folks have a 7-day outpatient behavioral health follow-up appointment. We have a less than 5% readmission rate to connections. We say to connections because we don't always have a clear view and insight into other providers and what their readmissions are. And we have a less than 10-minute law enforcement drop-off time. Of the patient demographics, between 50 to 55% of the individuals that we serve are dropped off by law enforcement at our back door. Again, law enforcement has their own office, their own bathroom. We want to make sure that when they're coming in, that they're getting the space to do any of the paperwork that they have. Oftentimes, they're going right back out onto patrol. 65% of the individuals that we do receive have a comorbid substance use disorder as well. So we're able to do the moderate medical detox with individuals. Patient satisfaction is really critical to us. As I mentioned before, we want to ensure that individuals have the ability to give us feedback on the services that they received. We welcome critical feedback. We want to hear that we're doing a good job, but if there's a gap or there's a need that we need to correct, we're more than happy to hear that. And we want to make sure that individuals feel that they're safe, respected, and have compassion and dignity in the services that are provided to them. We have an 84% satisfaction rate in our crisis observation, 92% in our inpatient crisis stabilization, and we have a 99% satisfaction in our behavioral health urgent care. The whole flow and process of this is to make sure individuals get exactly what they need when they need it by people who know how to provide the psychiatric treatment and care that they need in that time. Wanted to be able to provide some actual feedback that we've received from individuals. When surveyed, about 80% of connections patients who are the highest acuity and presenting a crisis would recommend us. One individual in our urgent care identified, "You understood the situation and didn't make me feel like I was crazy or out of it. I love that y'all take care of your patients." Another individual said that peer support is the best ever. "I'm a loner and I do not trust people, but here I felt safe and I know that people care about my well-being. I would like to thank the peer support specialist. He never judges and he works so hard to get us the help that we need. I went to Connections Tucson 5 years ago and they saved my life. I've been stable on meds and have not been back since. My friend who also went there recently said she was treated well there. Keep up the great work." We want to make sure that we're connecting with you all to find out what your thoughts, what your needs are, what you see high priorities for in the community. So that's the end of my presentation. I ran through it fairly quickly. I'd like to open it up to any questions that you all may have. I see that there's several in the chat. Oh, that's just folks identifying where they're from. Okay.
Hello.
Hi.
Hi, this is Bob. Thank you very much for the presentation. I really needed to be filled in. It's very important for me. I'm curious as to if you would, the slides that you have there are very informative and it's a lot of information. Is it possible to get a copy of those?
Yeah, I can go ahead and send those out. I'll have to connect with one of my colleagues here. The way we have it formatted, I just need to update the formatting so it comes across the same way that you saw it this evening.
Okay, thank you.
You're very welcome.
I have two questions.
Hi.
Hi, my name is Donna Lurie. I'm the board president at NAMI Eastside. The first question I have is, what do you see the role of NAMI volunteers to be in providing peer support and aftercare with support groups and mental health education classes?
Right. So because we're coming in fresh into the area, we're still learning what you all have to offer and how involved and engaged we can be with you. If there are support groups that are available, we would want to be able to share that information with individuals before we're discharging them. Oftentimes, if the individual is in agreement, we'd like to invite you all or one of the volunteers in to be able to meet with someone and be able to share with them the purpose and the services that you all can offer and connect individuals with. We'd love to have in-services with our staff so that our team understands who you are, what you have at your disposal, what you have to offer, and how we can best support you as well. It's a two-way street. So I would love to get more information about that, and perhaps Donna, you and I can connect the next time I'm in Washington.
Sure. My other question is that the healthcare authority in the state of Washington has created a program for certified peer counselors. And we're also exploring that for some of our folks. My question to you is, how would your peer support person relate to this healthcare authority certified peer counselor program? Are they going to be in sync with each other? Are they going to be in conflict? Are they going to be just parallel tracks? Have you thought about that?
I didn't know about that.
Okay.
Thank you for bringing that to my attention. But what I would say is I could see that as a connection and a joining of forces, if you will. It won't be in opposition. It may at times run parallel, but there may be other times where we're engaging and our peer support staff are acting as a liaison to connect them with a peer counselor. That would be the best bet. Yeah. Yes, Bob.
Hi, Heather.
Hi.
I've had a personal experience at Fair. Oh darn it! Sorry.
Fairfax.
Excuse me, at Fairfax. I know they're a for-profit facility, just like I think you are.
Correct.
And are you working in concert with them, or is there any competition, or how do you work with them?
So they're not part of our organization. How would we work with them? In the event that all of our inpatient beds are full, we may potentially reach out to see who else has an available inpatient bed. Are they a competitor? I think that there's enough to go around. I don't like to think of other folks as competitors. We are a part of the crisis system as it's going to be in Washington. We're going to attempt to move it forward in a way that feels good for everyone. We're not the panacea for everything. We are, though, going to fill a lot of the gaps that exist currently. We will meet with Fairfax. We will identify where they think there are needs, just like we will meet with and have met with everyone else. We've had quite a few conversations with folks at Evergreen to identify how we can make sure folks don't languish in an emergency room and actually get the care they need instead of just sitting in a gurney or the waiting room at the emergency room waiting for someone to treat them.
Yes.
Competition, I don't particularly like to compete with others in the care of human beings. If folks are coming to our door. So here's the thing, though. We're not worried. At the end of the day, whether somebody has the ability to pay for the services that we're going to provide or not, we're going to provide those services to that person. That is not the first thing that we're worried about. When we have individuals present to us, yes, we are going to ask for their insurance information. If they don't have their card, that's fine. We're going to ask them in the process of our intake and evaluation what their name is, what their date of birth is. We have the ability to look up in real time individuals' insurance. We're going to exhaust all possible efforts through insurance. At no point is somebody going to come into services and we're going to hold our hand out to them and expect to have payment before we resolve their issue. We have a group of individuals behind the scenes who do that. Our facilities are geared solely for the provision of emergency services to someone in acute psychiatric crisis.
Okay, so there's no charge for those people that are in an acute situation. Is that what you're saying?
Their services will be billed through their insurance program. That's how we get paid. Correct.
Okay. So that's how you get paid. Okay, okay, I was curious about that. Also, as your facility's got the King County grant, is that from property taxes? Are you funded through them?
So the 5 counties, the 5 facilities, that has not been decided yet. We worked with North King County Coalition. They invited us up and we have worked with them to open this process. I know that there is another 5 facilities that will be opening over the course of the next year to 2. And I believe that that's the crisis levy that was put out.
So are our property taxes paying for your facility infrastructure?
I don't believe so. I'm not sure I can answer that question right now.
Okay. And I don't know if Evergreen's paying anything or funding you at all either.
No, sir.
They're not. Okay.
Nope.
There are some other questions that have come up in the chat. So I'm making sure you know that. They want to know, when is the facility going to be open? Is it for adults or adolescents or both? So I'm just making sure
I
that
appreciate that,
questions
Donna.
are answered.
Thank you very much. I turned my chat off so I could see you all.
Thanks, Heather.
When,
okay. Yeah.
When is the facility going to open? Our target is the end of this next spring and beginning of summer. So I would anticipate June, July-ish. That's our target, understanding that, with construction, things move a little bit. If we can open earlier, we will. If it takes a little bit more, we'll open a little bit later, but the target is June, July timeframe. And then it's adult only at this point, right? So 18 years and older. If somebody presents and they're under 18, we are going to work with that individual to determine where we can help them get to so that they can have services provided to them in an appropriate manner. So we'll work with additional agencies and providers in the area. Where are patients coming from? Who's bringing them in? So patients are coming in by themselves. They can do a walk-in through our urgent care. Loved ones, their natural supports can be bringing them in. We've had individuals brought in by their pastors. We've had folks brought into our urgent care by their outpatient case manager, quite honestly. They're concerned about the individual, and they've been able to talk to them and let them know that they can receive additional services and potentially inpatient or observation services to ensure that they stay safe. Let's see. So maybe in percentages, family, friends, police. So between 50 to 55% of all the individuals that are brought into our facility are brought in by law enforcement. And those folks typically are coming through our back door. The folks that are coming in through our front door are, just as I said already, individuals coming in on their own accord, family members, community and neighbors may bring them in, loved ones may bring them in. So any way that they can get in, that's how we're hoping that they come to us. Timeline, ETA. It's just for adults. David, I'm sorry. What was your question here? I want to make sure that I get it. What happens to individuals who need stabilization more than 7 to 20 days? So just because we hit that 4-day mark does not mean we open the door and ask you to walk out. If an individual needs additional time to be able to stabilize, we're going to work with them and we're going to continue to provide services until the provider and the individual feels that they are safe to be outside of our facility. If there's even more need at that point, if we've exhausted everything, we may need to look for a higher level of care. But again, that's going to be working with the individual, with their natural supports, with their case management team to identify the most appropriate level and place for them to receive their care. So I hope that meets your question. Donna, yes, the Tucson facility does provide urgent care and observation for youth. And so some of our programs have youth services. Our Phoenix campus does not provide youth services. It's really part and parcel of what the community or what RFPs are put out and the needs of the community. At this point, when we were asked to come into Washington and answer an RFP, it was for adults only. That doesn't mean that down the road, once we've opened, that the other opportunities for providing services for youth could happen. That there's no hard stop on that, but it would be at a different facility. What address do I bring someone in crisis? Well, we are not open yet. And so we're off of 124th in Kirkland. So everybody, I can't remember the exact address. I can look it up before we leave. Does everybody know where the Olive Garden is? We're directly behind the Olive Garden up the hill. We're in an industrial area. We're about 2 blocks away from the police department. And so, yeah, we're right in Kirkland. But again, we're not open and we won't be for several more months. Is the team experienced to support individuals with eating disorders if vitals are stable? Or will the risk of medical decompensation due to not eating cause you to turn them away? Nothing causes us to turn someone away unless they're in acute medical crisis. So we have individuals who are experienced in treating eating disorders. That is not our bread and butter, if you will. We are truly trying to assist folks who are in psychiatric crises. If they are medically decompensating due to the fact that they won't eat, there is a point at which it becomes a medical emergency, and we would have to send them to the ED to have them assessed, evaluated, and then at that point, it's the medical professional's determination as to whether or not an individual is admitted to the hospital or not for their medical needs. If someone needs restraints, how is that handled? David, thank you for asking that. We are licensed and will be licensed to provide seclusion and restraint. So if someone needs restraints, our team is first and foremost trained to verbally de-escalate individuals. The last thing we want to do is put someone in restraints. We do use therapeutic options and safe clench. So throughout the process, we're going to be using verbal de-escalation to assist someone in figuring out, this is what the expectations are, here's how we want to help them. And if they are in an emergency situation, we will do a personal hold. If they need restraints. We do have a restraint room. We use humane restraints. That's the type that we have. The room is safe anti-ligature. There's no way for an individual to hurt themselves if we utilize it as a seclusion room. If they are restrained, our team works in concert with one another at the beginning of each shift. The staff on their assignment sheet is assigned to either the right wrist or the left wrist, or they're the person who is applying the restraints. We require our team to go through recertification and training every 6 months. The reason for that is, first, we're driving home. We want to verbally de-escalate folks first. Second, we want to make sure that that process is a coordinated effort and that it goes off without a hitch when we do have to restrain an individual. So our nurse is going to make sure that that individual has room in their restraints for appropriate blood flow. There's going to be someone watching that individual from the moment they walk in, they're brought into that room until the moment that they're released from that room. They document consistently every 15 minutes. Individuals are offered food, they're offered water, they're offered bathroom break. And oftentimes, if the person is still unsafe and needs to use the restroom, we have bedpans and urinals that our teams will use with them. So that's about that. I can answer more questions if there's more specific questions. Heather, you want to know approximately how many folks will we be able to serve on a yearly basis? So we're anticipating somewhere between 10 to 12,000. Our Tucson facility is able to manage about 10,000, and our Phoenix location, which is a flagship and it's our largest facility, we're serving close to 13,500 people a year. So quite a few. Do we do labs and blood work? Yes, we do. When an individual is brought in, we're going to do a urine analysis. We're also going to do a urine pregnancy test. That gives our prescribers information about medication if an individual happens to be pregnant. We're going to run the regular CBCs, THS, or TSH. Our docs have a standard panel that they run. And we're also able to manage folks who are insulin dependent and may need a sliding scale for diabetes. So our medical professionals are pretty adept at being able to handle the majority of medical considerations that an individual would be able to manage in their own personal life. Are there currently facilities like Connections in King County? I imagine there's some that are similar. I don't believe that there's any facility right now that has the full continuum of care that we provide. I would refer back to Edie or Donna to be able to answer specific questions about the providers in the area. Will we work in concert with a 90, 180-day facility in Monroe when they open? We're going to partner with everyone. And the reason we're going to partner with everyone is because we want to make sure that folks get appropriate care at the level of care that they need for the length of time that they're going to need it. Again, we're a stopgap. We're not the panacea for everyone. What are my credentials? I have a master's in counseling, marriage and family therapy, and I'm a licensed independent substance abuse counselor in the state of Arizona. Trained as a marriage and family therapist, so I'm able to do both marriage and family therapy and also substance abuse counseling. I ran a MAT clinic for many years, and I've run several inpatient psychiatric facilities over the last 30 years. How many patients can we handle at once? We're going to have a 32-chair observation, and we're going to have 2 inpatient facilities, 16 beds each. One is going to be designated specifically for ENT. Of course, that shifts and moves with what our needs are. So, with 32, it's like 64 individuals at a time if we're full. We anticipate that we will reach maximum capacity pretty quickly, based on all the conversations we've had with folks in the area already. Will we be overwhelmed when we open? I mean, probably a little bit. But overwhelmed as far as can we actually provide the services, we will continue to provide the services. Our facility in Phoenix is licensed to have 60 chairs. We've been up to 77 individuals in our observation because acuity was just really high in the community for a given reason. And that kind of moves, and we're never exactly sure when that's going to happen. Because we consistently focus on discharge at admission, our throughput is pretty quick. We're probably going to hit some barriers and bumps in the road when we get in there to make sure that we can discharge smoothly and cleanly. That's going to be a process by which we learn from the actual act of providing the services and moving people through. That's why it's so critical and crucial for us to meet with our stakeholders in the community and identify exactly who's out there, what services are available to individuals when they are out of their crisis situation. Are we concerned about being able to staff the facility? There's a huge shortage of providers. We've actually had folks reaching out to us already. Because we're a national model and because we lead the charge and we're the gold standard for this type of care, and Doctors Carson, Wilson, Williamson, myself, Dr. Margie Balfour, we're all out talking about and showing off and in educating individuals about our process. We've had multiple individuals that are already reaching out to us to inquire about employment. Now, am I concerned? I'm always going to be concerned about employment. The pandemic, if it did nothing else, taught most of us that it's a challenging time to have employees. So we'll continue to work with them. The facility is going to, oh, Heather, thank you. Heather provided the address right there. It's 11410 Northeast 122nd Way. So there we go. Any other questions? The next time I'm in the Kirkland area, I would love to be able to meet with you all in person and, you know, be able to provide more information. We have a newsletter that's going to be starting to go out to give updates to the community and keep you all updated on the progress that we're making with our remodel and our build out. KJ, we will be opening in late spring, early summer of 2024.
Sorry, got the jump on that
You got
one.
it.
Sorry.
You got it. I appreciate the assistance.
Apologies for that.
You bet.
Yeah.
Any other questions?
Questions?
I have one last one, which is
Yes.
my understanding is that the folks working with Connections are part of the 5-city consortium in North King County.
We have not been named as one of the 5.
Okay, because Kirkland is working with Bothell, Lake Forest Park, Kenmore, Shoreline, and I wasn't clear how Connections is working with those cities, or is this separate from that?
North King County came to us prior to the levy.
That's what I thought. Yeah.
Yeah. So we are not, at this point, we have not been named one of the 5.
Okay, so this is separate from the King County property levy. Okay.
Yes, at this point it is.
Okay.
Edie, it looks like somebody wants to know how to repeat the replay.
Oh, is that how to find the recording? Is that what they're asking maybe? It looks like that
Suzanne?
message went right to you, so.
Oh, I'm sorry. Okay, so Suzanne
Yeah.
said, Suzanne Grogan asked, could you repeat the way to see the replay?
Yes.
I don't know.
Yeah, if you're talking about the recording of this afterwards, it will be up on our website within a week. And I will put the link for that in the chat again real quick here. Thank you for asking that.
So if we want to do a follow-up with you, what do you suggest?
You can email me or you can call me. I will put my number. Email is probably the fastest and easiest way. You can also text or call me. Let me put my number in the chat. That went directly to you. Let me see if I can do it to everyone in the meeting. There we go. And again, the email is Heather Genovese at connectionshs.com. Make sure I missed my S. There we go.
Awesome. Well, thank you so much for coming and talking to us about the facility today, Heather. I think it'll be really, really cool to have this resource. I know when you mentioned where it was near the Olive Garden, I live really close to there. So I was like, wow, this really is going to be like right in the middle of Kirkland. So I'm very excited to see your process as you get things open up. And yeah, thank you so much for being here and walking us through it.
Wonderful. Thank you all for inviting me. And Edie, if I can, I will let you know the next time I'm in town. It's probably going to be a few weeks, maybe a month. I've got some other trips back east that I have to work on. We're opening in Virginia at the end of the year, so need to get back there and do similar activities with them. But I would love to be able to meet with you all and have a sit down and grab coffee with some of you the next time I'm in town.
Fantastic. Yeah, just keep us in the loop about that. And for everyone else that joined us today, thank you so much for being here, for asking your questions. I want to thank both Evergreen Health and Connections for sponsoring NAMI Eastside, especially for our luncheon coming up next week on October 5th. I'm going to go ahead and drop a link to that in case anyone's interested in coming. That's next week on Thursday. We're having a luncheon. Gonna be a fun time. Gotta get lunch and talk about our programs. It'll be wonderful. So thank you so much, Connections and Evergreen Health, for sponsoring us for that as well. And if those of you who attended today don't mind filling out one more thing for me, I have a survey that again, filling out these kind of demographic questions helps us to fund these kinds of programs for the future. And keep an eye out on our website for the next forum coming up in October 24th. We'll have more information on the website, as well as the recording from today's forum up in the next week. So yeah, thank you all so much for being here tonight.
Thank you.